In this segment, we will focus on high-grade poorly differentiated neuroendocrine carcinoma. Welcome back from Miami. My name is Aman Chauhan. I'm a medical oncologist at University of Miami, Sylvester Comprehensive Cancer Center. I lead a neuroendocrine tumor program here, and I also co-direct our Theranostics program. As we discussed previously, neuroendocrine cancers are not a single disease, but a complex bouquet of diseases, which vary based on the morphology of the cancer, how they look under the microscope, and how they behave clinically. So when we talk about lung neuroendocrine cancer specifically, I'd like to take your attention to the middle of the slide. These can be divided into NETs of lung, the well-defined neuroendocrine tumors, and there are two major categories, typical, atypical carcinoid, and the NECs of lung, the poorly differentiated neuroendocrine carcinomas, the small cell and large cell neuroendocrine carcinoma of the lung. In this segment, we will focus on NECs or large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma, which are by definition high grade or grade 3, and also unfortunately very aggressive diseases. In this slide, we are showcasing how these cancers look under the microscope. When a pathologist views a high-grade neuroendocrine cancer, it can be of either small cell variety, small round blue cells, or the large cell variety and very high Ki-67 index. In small cell is often 90% plus, and a lot of necrotic cells, and you can also have a very high mitotic index. Those are some of the key components and the data metrics that are used by pathologists to classify cancer as a high grade with help of these stains. When you look at the WHO classification of neuroendocrine cancers, there are 4 distinct categories, as we mentioned, and these are some of the telltale signs when we come to small cell and large cell. They often are positive for TTF1, signifying this sort of a lung origin. They also have a high Ki-67, so by definition, they will be more than 20%. However, we still use mitotic index primarily, but the WHO classification warming up to kind of testing Ki-67 and encourages the pathologist to test for Ki-67 in thoracic neuroendocrine cancers. And again, there are other immunohistochemistry stains that are often used, like chromogranin, synaptophysin, to help them differentiate between typical and atypical versus high-grade NEC. So these are all the things that goes in the background, and our unsung heroes, the pathologists, they often do the most heavy lifting and try to figure out the diagnosis for us, because without the right diagnosis, we get everything wrong moving forward, from picking the right type of scan, and then, of course, starting the right type of treatment. Just to kind of give you an example, if a patient is diagnosed with typical carcinoid or atypical carcinoid, we'll maybe do a dotatate PET as compared to small cell, where we do FDG PET. So getting the right diagnosis is very, very important. Let's look at the disease distribution when it comes to high-grade neuroendocrine cancers. If you divide lung cancer into a pie chart, about 12 to 14% of all lung cancers are small cell lung cancers. Nationally, about 12%, but there are certain hotspot areas. Previously, I used to work at University of Kentucky, cater to a lot of Appalachia patient, and the incidence there is much higher, or maybe almost 14 to 15% of all lung cancers are small cell lung cancers because of traditional use of tobacco in that area. With low tobacco prevalence use, the small cell lung cancer incidence is definitely less. And then about 2% of all lung cancers are large cell neuroendocrine cancers. So these are not trivial diseases. They form about roughly 14 to 16% of our lung cancers between the large cell and the small cell. Why it's important to study these cancers, besides that they form 14 to 15% of all thoracic cancers, is because of their dismal outcome. We have made very little progress in last 30, 40 years when it comes to small cell lung cancer. The outcome data, on this infographics, you can see the yellow line represent the long-term outcome from time of diagnosis for small cell lung cancers. And then the 5-year survival, unfortunately, is around 10%. In fact, it was about 6 or 7% before the era of immunotherapy. Now, in the era of newer immunotherapy drugs, about 14%, which is somewhat improved, but not at all where we want it to be. We want our 5-year survivals to be 50, 60%. We are a long way from that when it comes to high-grade neuroendocrine cancers like small cell and large cell neuroendocrine cancer of lung. However, there is some hope. So stay tuned. The last segment of my talk will discuss about some new breakthroughs. So how do we diagnose lung high-grade neuroendocrine cancers? Just like all cancers, the gold standard diagnosis is biopsy-proven confirmation. But when it comes to lung high-grade neuroendocrine cancers, it's tricky because sometimes we don't have luxury to get a lot of tissue. Many diagnoses are based on bronchoscopies and small FNA, so small needle biopsy, very limited tissue. And pathologists can sometimes be confused between atypical carcinoid and large cell because the tissue is very limited. Those are some of the challenges we incur when it comes to lung neuroendocrine cancers. So I almost always advise patients to seek another opinion if diagnosis is questionable, or seeing a pathologist or a neuroendocrine cancer specialist at high volume center, because the pathologist there would also by default more experience because they see a lot of these cases. And there's plenty of data, as I kind of outlined here in this slide, that between the pathologist itself, there's a lot of dichotomy in diagnosis. Sometimes two pathologists would not agree. And that's not because they're wrong or they're both right. It's just it's a difficult diagnosis, especially if the tissue is limited. So getting a second opinion doesn't hurt. And sometimes you might have to get another biopsy to get more and better tissue. So those are some specific nuances when it comes to neuroendocrine cancer of the lung. How do high-grade neuroendocrine cancer of lung present? Let's talk about small cell lung cancer first. It is extremely rare to diagnose at early stage. Like neuroendocrine tumor, the typical atypical, where we often find them early stage because they are slow growing and they're caught incidentally. By the time we diagnose high-grade neuroendocrine cancers like small cell lung cancer, it's oftentimes quite advanced because this grows so fast. By the time the patient comes to a cancer doctor or oncologist and getting full staging work, the tumor had oftentimes progressed. Almost 30% patients can have brain mets at the time of diagnosis, and many patients will have liver mets, bone mets, adrenal mets. So finding disease in early stages rather rare. Sometimes patients will present with certain paraneoplastic syndromes like SIADH or ACTH production, which gives Cushing syndrome, or muscle weakness, Lambert-Eaton syndrome. It's like a myasthenic syndrome. Some patients might have high level of calcium because of high level of parathyroid-related hormone, which causes your calcium to go up. Patient can present a lot of dehydration, weakness, altered sensorium, etc. So we always have to kind of keep our radars up for these paraneoplastic syndromes. And if the lab or clinical presentation or symptomatology suggest of one of these, we then need to confirm those and then start the appropriate treatment. This slide again shows what are some of the presenting features. For example, somebody has SIDH, syndrome of inappropriate ADH secretion. So what happens, the patient on lab work will have low sodium levels, and then on clinical presentation would have headaches, nausea, fatigue, muscle cramps, and also in a severe case has seizures. So those are some of the telltale signals. There are ways to confirm the diagnosis, and on confirmation of diagnosis, and we usually get our endocrine or nephrology colleagues on board, start patients on appropriate treatment. And the root cause of the issue here is the cancer. So an oncologist has to initiate the cancer treatment right away while we are trying to stabilize the electrolyte levels. Similarly, Cushing syndrome, patient can present with muscle weakness, edema, swelling, weight gain, and there are a set of treatments that are targeted to block the hormone production while we are trying to treat the underlying cancer, because that's going to fix the root cause. Are there any blood-based tests to aid the diagnosis? Unfortunately, no. For high-grade neuroendocrine cancers, we have traditionally used NSE, neuron-specific enolase. However, very poor sensitivity and specificity to a point where We don't routinely recommend use of NSC for either diagnosing or monitoring. Chromogranin A, again, not very accurate, especially when it comes to high-grade neuroendocrine cancer. So we currently don't have good blood-based test to confirm the diagnosis. The diagnosis is still incumbent on biopsy confirmation. There has been some recent advances when it comes to next generation sequencing and genetic testing of tumor tissue when it comes to specifically large cell neuroendocrine cancer or high grade neuroendocrine cancer. Dr. Reckman from Memorial Sloan Kettering did this important work, and what they did is they did genetic testing on large cell neuroendocrine cancer of lung patients, and they were able to really divide them based on the genetic signatures into two subcategories: the small cell like, if the patient had TP53 or RB1 mutations, or non-small cell like. So there is definitely growing role of molecular testing in understanding the biology of these cancers. And I routinely do NGS for lung high-grade neuroendocrine cancers, looking for targetable mutations, understanding their biology. However, this is not mainstream yet. This is not fully adopted, or it's not mandatory to do to classify these cancers. Next step, after we have diagnosed somebody with high-grade neuroendocrine cancer, we then have to stage the cancer. The staging will determine our treatment. If it's early stage, treat very differently with different intention as compared to advanced or metastatic disease. There are two main ways to classify or stage the cancer. One is the typical AJCC classification using TNM, but the more commonly used with small cell lung cancer context is the VA classification, where we have just two categories: limited stage or extensive stage. Limited stage implying that the tumor is limited to one part of the thoracic cavity, which can be covered under one radiation field. Extensive is that it is widely spread either to distant metastatic disease, or within chest it's just too extensive or involves pleura or has pleural effusion, and it cannot be covered under one radiation field. So those are the ways where we determine the staging. And why it's important: for those extremely few cases that we are lucky to catch in stage one very early, there is role of surgery. However, these are exceptionally rare scenarios. As I mentioned in the screen here, only 5% or less patients with small cell lung cancer will be diagnosed that early in stage 1 or 2. Majority of patients are either stage 2 or 3 or stage 4. And based on the stage, the treatment for local or limited stage would be chemoradiation with an intention to cure. However, unfortunately, despite doing the chemo and radiation, many patients unfortunately would relapse, so will have to be monitored very closely. Very recently, there was a study done that called Adriatic study. It tested the role of immunotherapy after patients have gone through chemotherapy and radiation for limited stage small cell lung cancer, and they did find improvement in the outcomes with addition of immunotherapy for 2 years after chemo and radiation. So that's how we treat late stage disease. But as I mentioned before, majority of our patients have extensive stage disease. 2 of the 3 patients diagnosed small cell lung cancer would have advanced disease at presentation. So for rest of my talk, I will focus on extensive stage small cell lung cancer and large cell neuroendocrine carcinoma patient, and how do we go about treating them. For the longest time, we have used a treatment cocktail called platinum-based doublet. Previous to that, we used to use a drug regimen called CAV, very toxic, cyclophosphamide, adriamycin, and viscristin, but effective, but toxic. Then in 1980s, we started using platinum doublet with carboplatin etoposide, cisplatin etoposide, and found very similar results, but much better side effect profile. So since 1980s, that has really taken over as the frontline treatment. And today, if you have a patient with small cell lung cancer in South America, in North America, in Europe, or India or China, that is our go-to treatment for metastatic cancer, the platinum doublet. The platinum-based doublet works very well. In fact, 7 out of 10 patients will respond favorably. The problem is that the effect of the platinum doublet doesn't last long. And that's where there was a need how to improve the durability of response. So a few years back, immunotherapy with atezolizumab was added to carboplatin etoposide. Patients were either randomized to carboplatin etoposide plus atezolizumab, which is an immunotherapy drug, versus standard of care carboplatin etoposide. And what we see in this study called IMPAR 133, the patient who got immunotherapy in addition to chemotherapy, they did better overall with median survival improvement in overall survival of roughly 2 months. That sounds a small improvement, but consider this was first big breakthrough after probably 40, 50 years in our field. So welcome addition. Now, the current standard of care for small cell lung cancer in the US at least is carboplatin etoposide or cisplatin etoposide plus immunotherapy and maintenance of immunotherapy after chemotherapy as a frontline treatment. In fact, I have several patients who are now 2 or 3 years into the treatment. So you can see here the tail end of the curve that there are patients who does remarkably well by addition of immunotherapy. So that has been definitely transformative for some patients for sure. Similarly, another type of immunotherapy drug, another manufacturer called durvalumab, same class of drug, both are immune checkpoint inhibitor, but a different brand, showed very similar results. So these things are real. It wasn't just one off. Both durvalumab and atezolizumab are now FDA approved for frontline use in small cell lung cancer. What do we do about second line therapies? So these patients may benefit for 6 months, 7 months, 8 months with the frontline chemo or with immunotherapy, but we know majority of patients would eventually progress. And when they progress, this cancer becomes extremely difficult to treat. The response rates for subsequent treatment usually are less than 10%. Especially if they're platinum refractory. That means if the cancer came back within 3 months of finishing the frontline platinum-based chemotherapy. So it becomes a very difficult disease to treat. However, a few years back, there was a drug called lurbinectedin that was FDA approved based on a smaller study, showed some impressive response rate. And now we know even better if patient has platinum sensitive disease, but also works in platinum refractory disease as well. So there are some other options that can help us buy some more time. But one of the issues with these subsequent second, third line treatments, lurbinectedin being one of them, topotecan another one, they are pretty tough on bone marrow, can cause cytopenias, fatigues, infection risk. And if the effect is also not highly durable, that means it might stabilize the cancer for a few months. But we are always longing for treatments that can lead to long-lasting results. These are the list of the currently approved treatments or recommended treatments for small cell lung cancer. And we often use the same cocktail for large cell neuroendocrine cancer because so rare dedicated studies on large cell neuroendocrine cancer of lung are extremely few. So we often use data from small cell lung cancer. Now, I on purpose showed you this list without a drug which was FDA approved in May of this year called tarlatamab because the rest of the talk will be largely focused on that drug is now approved based on a phase 2 study and is the recent addition to this list and is creating some waves. So how would we find new breakthroughs, new treatments which can break the log jam and really lead to some improvements in outcomes for high-grade neuroendocrine cancer patients like small cell lung cancer is through clinical trials, drug development. And that's where this new drug called tarlatamab comes in. Currently, tarlatamab is the only FDA-approved DLL3 targeting BiTE drug for small cell lung cancer, but there are several other in development with some very exciting data that I'll share with you. But let's talk about the main drug first before we go into the DLL3 BiTE targeting. So tarlatamab, and this is public information now, when it was tested in small cell lung cancer patients, almost 70% patients reported some benefit. This is huge. Out of those 70%, large chunk of these patients, almost I think 40%, showed improvement in disease. That means it showed partial response, shrinkage of disease, and other 30% some stability. So together, 70% had some benefit. This is in stark contrast to a lot of treatments that we often use for fourth, fifth, sixth line treatment with 10% benefit or less. So huge, I would say almost groundbreaking results that led FDA to approve it based on a phase 2 study. So the phase 3 is ongoing, but the results were too good to be ignored, and we want the access to for this important drug for our unmet need patients, small cell lung cancer specifically. So I'm glad that this drug is now FDA approved and it's commercially available, and a lot of centers are now able to administer it to small cell lung cancer patients who may not have access to clinical trials. On an average, this drug was found to stabilize the cancer for 9.7 months. And on this is one of my own patient, one of the first few patients on phase 1 trial with this class of drug. And this patient had progressed through 4 or 5 lines of treatment, and we tried this drug, and 2 years later was still in complete response. Those kind of responses are extremely rare with traditional chemotherapy drugs. So that's the power of these newer type of immunotherapies with deep durable responses, and that really personally led a lot of optimism for me with this class of drug. So what is DLL3 bite, and what about large cell neuroendocrine cancer and not small cell lung cancer? How do we get them this class of drug? So let's understand what is DLL3 and bite targeting. Just like somatostatin receptor that is present on low-grade or well-defined neuroendocrine tumor, DLL3 is highly expressed in high-grade neuroendocrine cancers. This is a notch pathway protein called delta-like ligand 3, which is expressed on high-grade neuroendocrine cancers. There is this drug, the monoclonal antibody, that has 2 arms. One of its arm attaches to the DLL3, which is expressed on the tumor. The other arm of this drug attaches to the T cells. So that's why it's called T cell engager. It's a bispecific T cell engager. So once it attaches the tumor, it engages your own or patient's own T cells and bring them closer to the tumor cells, activates them, and that causes inflammation and cell kill. So it's an immunotherapy drug which is really engaging your own immune system to fight against the cancer. It's just bringing them closer to the cancer cells. So that's the rationale behind it. And how commonly is this DLL3 expressed in high-grade neuroendocrine cancers? Well, in small cell lung cancer, almost 80% of them would have DLL3 positive tumor. But large cell neuroendocrine cancer, not too far behind, almost 75% of large cell neuroendocrine cancer of lung will express DLL3. And this is true for small and large cell outside lung as well, because we do have rare patients who have small and large cells of bladder, ovaries, kidneys, colon. So this could be a promising treatment for even extrathoracic high-grade neuroendocrine cancers. Currently, several drugs are under development. Some of them are BiTE antibodies, so bispecific T cell engagers. Some are tri antibodies, and some are even quadrivalent, so they'll attach to 4 different areas and try to bring the T cell closer to the tumor cells. So a lot of exciting drug development happening in terms of T cell engagers targeting DLL3, and I think the future is very bright in this area of drug development. I would like to share some data from one of the studies, the first in human studies, testing a drug, very similar drug to tarlatamab called obrixtamab. This name is not fully finalized because it's not a commercial drug. It's still under the investigation, but these data are in public domain. So BI, the sponsor of the study, is testing this drug in all high-grade neuroendocrine cancers. Small cell lung cancer, large cell neuroendocrine cancer of lung, and outside lung. It's a first in human study, so they were testing smaller doses and the larger doses in different regimens. And now they have some set of data that they revealed last year and this year at World Lung Meeting. I'll kind of showcase some of that updated data for the audience. About 53% of patients in this study was small cell lung cancer, 38% outside lung high-grade neuroendocrine cancer, and about 8% large cell neuroendocrine cancer of lung. So they had a good blend of everything. And before we talk about the effectiveness of this drug, quick word on the toxicity. This is an immunotherapy drug and has a very unique side effect profile. When it engages the T cell, it is causing an inflammation to develop. And when that happens, if one of the signs of inflammation the patient can have, fever and chills, that's called cytokine release syndrome. And these chemicals that are released during inflammatory process, the cytokines, can cause these fevers and chills. So those are okay. And fortunately, majority of patients, so almost 60% of patients who develop these side effects, had the low grade or the milder variety of CRS syndrome, the fever and chills. But around 5% or under can develop more severe variety of CRS syndrome. You can have shortness of breath, hypotension, and other issues. So that's why first 2 cycles of these treatments are given in the inpatient setting, where patients monitor for 24 hours after infusion for any of those complications. Besides that, some minority patients reported dysgeusia, so loss of taste, very unique side effect to this class of drug, and extremely rarely can cause autoimmune neuropathy, where neurotoxicity, where patient can get this syndrome complex called ICANS, so aphasia, mental confusion, sleepiness, etc. Again, fortunately very rare, but needs to be aware as we are learning more about this drug. And these are still under drug development and experimentation, so we are learning about these things more and more and trying to understand how to best treat them as well. But large majority of patients tolerated it well and can be managed for most of these adverse events. Now let's talk about the benefit and effectiveness of these drugs. Just like tarlatamab, the preliminary data from objective study are very encouraging. These are patients heavily treated with previous chemotherapies or other immunotherapies, and we still found very effective response rates from 20-30% range in different subset. Specifically at a higher dose, we saw robust response rates in heavily pretreated patients. And this was true for small cell lung cancer, as you can see here in the waterfall plots. The bars which are hanging upside down, that shows the amount of patients who showed partial response or disease shrinkage. So that was true for small cell lung cancer. Patient who had outside extrathoracic neuroendocrine cancers, so small cell or large cell cancer of GI origin or other organs, and also large cell neuroendocrine cancer of lung. So it doesn't differentiate as long as you have DLL3 expression. This class of drugs seems to benefit regardless where the site of origin is. So this is fantastic news for our high-grade neuroendocrine cancer patients. However, this class of drug is still under investigation. Only FDA approved for small cell lung cancer, tarlatamab, and other agents are under investigation in different phase 1, phase 2, or phase 3 trials. One of the things that I mentioned earlier is poor durability. That means even if the chemo works, it only works for a few months. That is different when it comes to BiTE antibodies. We have several patients who continue to have good, robust responses for several months. I shared an example of my own patients with 2 years complete response. So those are the kind of deep, durable responses we see with novel immunotherapies. Of course, there are patients who don't benefit, and we're going to continue to strive for better treatments for them. But it's very refreshing and a welcome step that many patients are benefiting from this DLL3 BiTE targeting and are showing deep, durable responses. This is one of the case for large cell neuroendocrine cancer of lung, which was recently presented at World Lung Meeting, almost 22 months, and continue to have great response with DLL3 BiTE targeting. So again, just to showcase that it's not just a small cell specific drug, it works for large cell and needs to be explored further in various subset of high-grade neuroendocrine cancer. Last but not the least, I mentioned almost 30% of patients with small cell lung cancer and other high-grade neuroendocrine cancers can have brain mets. So this class of drugs, does it work in the brain? Well, preliminary data from another study led by Harpoon Therapeutics, Dr. Chaudhary presented data at World Lung, and there seems to be some hints that this drug is effective in brain as well. Again, larger data sets would be needed to confirm this, but these are definitely very encouraging early signs. So what is the future for DLL3 targeting in high-grade neuroendocrine cancers? I think we have a great start with the BiTE targeting. Tarlatamab is already FDA approved for small cell lung cancer. Several other drugs are in development for small cell and large cell and extrathoracic high-grade neuroendocrine cancers. There is now the next wave of trials that are combining these DLL3 agents with standard of care chemotherapies. We have a couple of trials already up and running at University of Miami with combination with lurbinectedin, combination with frontline platinum-based chemotherapy, combination with topotecan. So those are the logical next step. When you have a very effective drug by itself, then you're going to combine it with other effective drugs and hope that the overall tolerability is there and the efficacy improves. There are also another classes of drugs that are targeting DLL3, radioligand targeting with radioactive drugs, very exciting, and CAR-T. These are engineered T cells which targets DLL3 positive tumors, and there are some promising drug development in that space as well. So very exciting times for DLL3 targeting. Just for completion, besides the DLL3, are there any other exciting drugs when it comes to small cell lung cancer, large cell neuroendocrine cancer of the lung? Last year at World Lung Meeting, a large phase 3 study from China suggested that combination of this novel VEGF TKI called alotinib, when combined to standard immune checkpoint inhibitor, led to improvement in overall survival when this combination was added to standard of care platinum-based chemotherapy. However, in past, several studies done in the Eastern population has not really panned out in the Western population. So although these are encouraging signs, I think it'll be important to investigate these classes of drug in patient populations from the US or Western Hemisphere to confirm these sort of findings. The other combination that is currently being investigated is a combination of immune checkpoint inhibitors, immunotherapy drugs with PARP inhibitors. These are drugs that damage the DNA and prevents the DNA repair in certain cancers, and there's some data to suggest that it may benefit. And based on preclinical data, we ourselves did a small phase 2 study where we combined a PARP inhibitor called rucaparib with nivolumab, an immunotherapy drug, after patient had completed the platinum-based chemotherapy and maintained on this regimen. And what we found that at 12-month mark, almost 90% patients were still alive. And at 2-year mark, 54% patients were alive, which is definitely significant when it comes to small cell lung cancer patient population, needs to be investigated further. My colleague, Dr. Kareem, is studying this concept as a combination of PARP inhibitor and immune checkpoint inhibitor, larger randomized study in a cooperative group study. And she revealed some preliminary findings last year at World Lung and ASCO, and that suggested that there might be some merit in the combination, some hint of improvements in the combination arm, but we're looking for a longer follow-up and mature data set. Other important advancements of note in high-grade neuroendocrine cancer of lung is radiopharmaceutical targeting. We discussed a little bit about DLL3 earlier. Now, radiopharmaceutical targeting, it's a concept where we use a drug that attaches to a protein or receptor that is expressed exclusively in that cancer cell. And this drug is radioactive because it's linked to a radionuclide, many times lutetium-177, but could be any other heavy metal with emits ionizing radiation, lead-212, actinium-225, etc., etc. There are already 2 drugs FDA approved, one called Pluvicto for prostate cancer, the one Lutathera. But what if we had a marker for high-grade neuroendocrine cancer of lung? And we do. So we now know that about 30% to 40% of small cell lung cancer patients can express somatostatin receptors. And we often use Lutathera or lutetium-177 dotatate, which is a radiopharmaceutical drug that targets somatostatin receptor positive tumors. Why don't we use something like that for small cell lung cancer? Well, the preclinical data does support use of PRRT for somatostatin receptor positive tumors. And there is some early human data as well from small phase 1 studies where PRRT was used in somatostatin receptor positive tumors. This is a small cell lung cancer patient, as you can see, and the tumor almost disappeared after 4 cycles of PRRT. Again, these are very small early studies. And what we want to see is these results consistent, can be reproduced, and how long these drugs work. We know small cell lung cancer is a very radiosensitive tumor, but would these results be durable? So that's where the next generation of more definitive studies will come in. Another study by Dr. Kim suggesting safety of combining PRRT and immunotherapy in small cell lung cancer patient. However, the long-term follow-up data is needed. So what's going to happen in this space? Well, stay tuned. There are not one, but several clinical trials in development, which will use somatostatin receptor targeting by radiopharmaceutical in high-grade neuroendocrine cancers, specifically small cell lung cancer. And these trials will be testing PRT agents, both beta PRT with lutetium-177 and alpha PRT with actinium-based drugs, in combination with frontline small platinum-based chemotherapy and immunotherapy agents. So very, very exciting developments in small cell lung cancer space. And last but not the least, if we can target somatostatin receptors, why not DLL3, which is expressed in 70 to 80% of all small cell lung cancer? Well, there is very exciting developments in that front as well. Last year, there was data at ASCO which showed that this targeting can be used for theranostic purposes from preclinical modeling. The tumors express DLL3, can be radio labeled for detection on a PET scanner. And if they can be detected, they can be therapeutically targeted. So stay tuned. Very soon you will see trials testing DLL3 targeted radiopharmaceutical in phase 1 development for both, again, alpha and beta based radiopharmaceuticals. With that, we will conclude, and this is my summary slide. It's very important to know that this is a very aggressive subset of neuroendocrine cancer, the high-grade neuroendocrine cancer. So urgency is very important. This is not something that you want to take lightly and you want to seek care immediately. Some of these tumors can have very rapid doubling time, as low as 2 weeks. So you really want to seek care immediately. Frontline treatment is pretty standard, so don't waste time in seeking a second opinion at a far-flung place. You want to get started soon with your regional provider. Standard chemotherapy or mix of chemoimmunotherapy is pretty standard, so it's really important to get started soon. There are a lot of developments with second, third, and fourth line treatments, so getting another opinion at high volume center to future-proof what will be our fallback option for second, third, fourth line is very important, and the sooner the better for that, but not at cost of delaying early treatment. In that context, I would like to give a small plug to one of the studies that is under development at our center, where we will be using an immunotherapy drug combination called ipilimumab-nivolumab in combination with this new type of immunotherapy drug called an oncolytic virus, Seneca Valley virus, which targets high-grade neuroendocrine cancers like small cell lung cancers. In this slide, you can see one injection of Seneca Valley virus into these tumors in the mice eradicated these tumors and had a durable long-term cures. So we are really hoping to translate this concept from lab to humans, and we are very close to launching this. Maybe another 2 to 3 months, we should be up and running for enrollment in first in human phase 1 study. So again, just to highlight that there's a lot of exciting drug development happening to fulfill this critical unmet need. We need more drugs, we need better drugs for high-grade, poorly differentiated neuroendocrine carcinomas. With that, I would like to conclude. Thank you again for tuning in. I know it was a very exhaustive, comprehensive session, but each facet of both low-grade and high-grade neuroendocrine cancers is complex, nuanced. So please use this resource as a brief primer and discuss your specific case with your oncologist for further details, and look for more resources on LACNET websites for further details on these specific trials that we discussed. Again, thank you so much for the opportunity to talk to you. Until we meet again.
Welcome back for our question and answer session. As a reminder to our audience, this question and answer session is for educational purposes only, does not substitute for medical advice. Please talk to your medical team with any concerns or questions about your individual care or treatment. We have over 30 questions. We're going to try to get to as many as possible on the topic of lung neuroendocrine cancers that are in the area of Dr. Chauhan's expertise, but we may not cover all the questions. And we, just so the audience knows, we don't necessarily address these questions in order that they were submitted, but instead in an order that makes sense. And we will address general questions only, and Dr. Chauhan will be answering the questions generally as well. He cannot provide specific feedback on your specific situation. So thank you, Dr. Chauhan, for an excellent presentation, well, two presentations that spans the wide range of lung neuroendocrine cancers. We're really excited to have you here. Thank you for attending to this special population and topic. And with that, let's get to our questions, which is, if the NET tumor is found in the lung, how is it determined if this is a lung NET primary or if it originated from somewhere else?
Great question. The pathology is the key for sure. The pathologists have a way to differentiate different type of neuroendocrine tumors based on the looks, what we call morphology. So pancreatic neuroendocrine tumor might have a different pattern. Lung nets, for instance, they might have what they call salt and pepper chromatin. So one is looks. The other is certain immunohistochemistry stains. Now, certain stains or dyes that we often use for neuroendocrine cancers, they are expressed across the spectrum in lung nets, GI net, pancreas, like chromogranin would be present in everything, synaptophysin would be present. But certain like TTF1 in certain subgroups of neuroendocrine cancer of lung origin might be present in the lung. So those are some additional clues, especially for high-grade neuroendocrine cancers, that's the case. And also we have to factor in the imaging. If we have a big tumor in the colon or the pancreas, clearly it sounds more like a GI neuroendocrine cancer, as compared to we have a clearly defined thoracic primary on the PET scan or a CT scan. So we really have to piece together all this information, but the pathologist would give us the most important clue that looks like a thoracic typical carcinoid or atypical carcinoid.
Yeah, so the pathologist review is really key. Thank you for clarifying. This is another excellent question. Which lung neuroendocrine cancers are more likely to spread, and what characteristics make it more likely to spread?
Very challenging disease for that particular reason. Now, between the gradation, you've seen a neuroendocrine tumor of lung origin can be typical carcinoid, atypical carcinoid, those middle of the road tumors with unpredictable behavior, and the neuroendocrine carcinomas, the small and large cells. Now, in small and large cell neuroendocrine carcinoma, it's a very predictable behavior, very aggressive, and they often tend to spread early, metastasize. They can go to liver, adrenal gland, brain, bones. So we often look at those areas. The typical carcinoid, very few of them metastasize. A lot of them are caught very early. That's why a lot of them would be cured with surgery alone. But they can certainly metastasize, occasionally to liver, and some other organs. Atypical carcinoma are very challenging. First of all, they're super rare. And the reason why they are atypical, they don't really follow a typical pattern. So I've personally had patients under my care who have presented with brain metastases or mets in the eyes and the retina and some completely weird locations, or skin or cutaneous mets. So you really need to have, keep your radars up based on individual symptoms or clinical manifestations. You might want to consider certain areas of scans to rule out metastases. But low-grade nets, unlikely to metastasize, and if they do, liver is probably going to be for distant metastases. For atypical, yes, liver, they can metastasize, and very rarely, I think in the literature, about 5% risk of brain mets for atypical or higher grade neuroendocrine. Now that risk increases quite a bit in large cell neuroendocrine cancer, about 10% risk of brain mets, and small cell, almost 30% risk of brain mets.
Yeah. Well, thank you for addressing the range too of what can happen. So you mentioned that it can spread to other areas. How would you know if a lung neuroendocrine cancer has spread to other areas? What symptoms should you look for?
Oftentimes, we don't rely on symptoms. That's why a patient who is early stage and is at risk of relapse, we depend on our scans or imaging for surveillance. Because many patients are caught asymptomatic, so we don't really fully rely on just symptoms alone. Clearly, if patient has headaches, blurry visions, intractable vomiting, just too much of nausea, vomiting, and projectile vomiting. That those are symptoms of raised intracranial pressure, so some sort of a tumor in the brain. So that will prompt me to do an MRI to rule out any concerns in the brain. If patient has bone mets, they will often have pain that is just not going away, and it's very specific location, unlike our musculoskeletal pain, achy joints. Unlike those, these bone mets pain, they'll be localized, they'll be fixed, they'll be always hurting at that particular spot. That'll trigger us to do an appropriate CT scan or MRI based on the location. So the symptoms would be individual and also organ specific, and the tumor volume specific. So a big bulky tumor might have more symptoms as compared to, but many patients are asymptomatic, and that's why we really surveil or follow patients based on the imaging. And the imaging, the frequency of it varies based on what type of neuroendocrine cancer are we surveilling. We don't want to overscan patients, right? So somebody with typical carcinoid stage 1 had a good surgery, we don't really want to scan them every 3 months or 6 months, just because the risk of relapse is very low as compared to small cell lung cancer, where the risk is very high. Even in early stage, I often surveil them with scans every 3 months. So it's not one size fit all. It's based on individual risk, staging, and what morphology, what type of neuroendocrine cancer we are surveilling.
Oh, thank you for that. And that actually touches on this question. So let's take this as a follow-up. How long should someone continue getting scans, I guess, particularly after surgery, to remove the lung neuroendocrine tumors, and which scan's ideal? I know, Dr. Chauhan, I've had some people say to me that their doctor, their provider, who may not be a NET expert, might stop scanning after a certain number of years. So is there a certain length of time you would recommend getting scans?
This is an area where we probably need more data and more research. One of the issues with typical and atypical carcinoid, these are rarer cancers, and we don't have data, high quality data, looking at long-term follow-up. At best, we will have patients who've been followed for 5 years and then 10 years. Extremely few patients who've been followed with good quality scans and good quality data beyond that. Can these tumors come back several years later? Yes. I think providers like me who just do this or focus on neuroendocrine cancer, we have patients in our practice who had relapse disease after 15 year, 18 year, 20 year. However, those are extremely few cases. In my experience, most patients, if they really relapse, it's within 5 years to 5 to 10 years. For atypical carcinoid, it's within 5 years. Typical carcinoids, being a slow growing type of tumor, can go up to 10 years. Small cell lung cancer, within 2 years itself. If there is residual micrometastatic disease, it will manifest itself within 2 years itself if the cancer is back. So again, no one size fit all approach. But with typical carcinoid, the lifelong risk of relapse is so low, especially in early stage cancer, and cumulative risk of potential, too many scans, and these scans with CT scans oftentimes have iodine dyes, which are not good for kidneys, and radiation. So it becomes a risk benefit balance, right? So I would scan them from anywhere between 5 years for sure, and beyond 5 years based on individual risk patient factors. Some patients are very anxious and they rather like to know what's going on, and stage of the cancer. For stage 1, I would probably have the least concern for typical carcinoid, and I'd probably peel off scanning sooner than later. Atypical carcinoid, I am worried, especially stage 2, stage 3, with some lymph node involvement that they might relapse. I do like to watch them a little bit closer for 5 years and beyond. And I probably would stop scanning beyond 10 years for everybody. If they've met that time point, I think we are usually good.
Okay, so looking at about a decade in general. And you mentioned that sometimes there can be spread to the brain. Do you recommend a baseline MRI of the brain, as long as can spread to the brain?
For small cell lung cancer, yes, it's actually standard of care. Every patient who's diagnosed with small cell lung cancer needs to get a baseline MRI, because almost 30% patients can have brain mets with small cell lung cancer. This risk of brain mets is very low for typical and atypical carcinoid. So it's not needed at baseline. And every patients do not need an MRI brain for typical carcinoid, especially unless there are concern, patient-specific concern. If there are headaches that cannot be explained by anything else, blurry vision, any of those symptoms, focal weakness or numbness or any neurological deficits, clearly we should investigate, but is not needed. And I would like to reassure majority of patients, I guess in this webinar, majority of patients probably belong to the well-differentiated neuroendocrine tumor category than typical atypical carcinoid. Brain mets is highly unusual. I do want to reassure you that that's not the typical presentation, and the risk is very low for brain involvement.
Thank you for the reassurance. This is an interesting question. There's been talk about increasing prevalence. What is thought to be the cause of the increasing prevalence of NET cancers?
It's $1 million question, and everybody from lung world to GI world is asking, because if you look at the incidence of neuroendocrine tumor, we see that there's a consistent and constant spike in the incidence every year by year. It sort of seems like going up, regardless whether we are dealing with GI or lung or pancreatic origin or neuroendocrine tumors. In fact, if you look at the breakdown, probably lung is showing the most spike in terms of increase in the incidence. We don't really know why. It's definitely better diagnosis. We scan a lot more people, a lot of incidental diagnosis, patients going into ER for pneumonia or some other chest issues. Sometimes patients have been caught to have typical carcinoid because they were getting an echocardiogram, and during the technician, when they were doing an echo, they saw like a mass in the chest, which prompted a CT scan. So a lot of asymptomatic patients are being diagnosed incidentally because we are doing a lot more scans. Our scans are also getting more sensitive. For example, dotatate PETs and these kind of scans, they're picking up smaller diseases. A lot is also due to awareness about this condition. Neuroendocrine tumors used to be not so well known, and hats off to patient advocacy groups and educational groups like yourself who are really championing in spreading the awareness about neuroendocrine cancer. So 10, 15 years back, very few doctors knew about it. Now a lot of doctors know about it, and diagnosis not getting brushed under the carpet. If somebody's diagnosed with neuroendocrine tumor, they are getting their due diligence. They're getting referral to an oncologist for proper staging workup. Our understanding of different neuroendocrine tumors has also evolved just in front of my eyes. The way the pathologists used to describe neuroendocrine tumors is also evolving, and that's because our understanding of these tumors are getting better. So I think we're just getting better in capturing the diagnosis. Is there an environmental factor to it that is responsible? That we are not sure yet. That's an area of study that we should study. If this risk or incidence continues to go up over next several years or decade, then clearly there is something beyond just better understanding and diagnosis that is causing these cancers to happen more frequently. And that is yet to be discovered, that is yet to be studied formally.
Related to that, someone submitted this question. The WHO did not set a classification of lung NETs based on Ki-67. What is your take on that? And if you could explain what this means as well.
So we've all heard of Ki-67. This is one of the immunohistochemistry biomarker that we use to classify or stratify the grades of the neuroendocrine tumor when it comes to gastroenteropancreatic neuroendocrine or GI origin neuroendocrine tumor. The lung pathology committee is distinct from GI. So we are trying to bring them together and kind of make it very seamless. But as of today, the pathology group for the lung are a separate group and the GI is separate. That's why you see subtle difference in the terminology, right? In lung, we say typical carcinoid, atypical carcinoid, and then large cell and small cell. In the GI world, we're kind of moving away from the carcinoid. We're kind of establishing grade 1, grade 2, grade 3, well differentiated, and then poorly differentiated. Because of those, differences, there's different committee who define lung neuroendocrine cancers. They rely on mitotic index. to classify or grade thoracic neuroendocrine tumors. So Ki-67 is not how we classify or grade lung neuroendocrine cancers. However, in last iteration of WHO classification for lung, they do acknowledge growing role of assessing or evaluating Ki-67. In fact, they encourage pathologists to run Ki-67. And once we have more data and how it fits and how we can use this information in the lung world to further classify, I foresee in future iteration, we will use Ki-67 formally to classify thoracic neuroendocrine neoplasms as well. But right now, Ki-67 is encouraged to be investigated, but the classification is based on mitotic index. That's number of mitosis happening under per high power field. So they count those, and based on that, we classify.
Thank you for that thorough answer and explanation of that. How about DIPNEC? How is DIPNEC differentiated from multifocal pulmonary net metastasis? And if you could also explain what DIPNEC is.
So get ready, Lisa. DIPNEC stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia.
A mouthful.
It's a mouthful. So I like the word DIPNEC. It's easy. It is not very well understood entity. Okay, and primarily because it is very rare. Some people debate if it's even a neoplastic condition. Some people believe this is pre-neoplastic or sort of precursor, that this happens first and then may evolve into a lung net. So we are still kind of understanding what it means. However, there are certain differences between a bona fide typical carcinoid or lung net versus dip niche. The dip niche are oftentimes very small neuroendocrine tumorlets. Sometimes they can be large, and that's where the questions come, multifocal pulmonary net. But oftentimes they are under 5 millimeter. Sometimes they might not even invade the basement membrane. So pathologists usually would use these clues to say this is lung net versus dip niche based on the pattern, size, and location. However, we are uncovering that there could be larger tumorlets beyond 5 millimeter that will put them into actual lung net category. And then maybe there are, also another form of dip niche. My personal take is all of these are a spectrum, and they might not be a distinct entity that, dip niche is like day and night different than smaller lung nets. So I think it's a spectrum of disease. They're all of neuroendocrine origin. They all have the commonality of some common biomarker that's stained for neuroendocrine biomarkers. And they just fall into different spectrums. So dip niche might be maybe very early or precursor, and then typical atypical carcinoids as it gets more aggressive or acquire more mutations. That's my hypothesis. I think we need to study more on these, these rarer subsets of lung nets.
We need more data. Thank you. Thank you for that. What about histamine secreting lung nets? What's the incidence of that?
Yes, very rare, extremely rare, in fact. Lung nets in general, majority of patients are non-functional. That means they don't secrete any hormones, they don't secrete any chemicals that will give additional symptoms. However, some lung nets can be functional, and some of those are usually carcinoid syndrome where there's some secretion of serotonin. Some can have secretion of ACTH, so giving Cushing syndromes like picture. Certain lung nets can secrete bradykinins, giving symptoms of asthma-like symptoms, wheezing, bronchoconstriction, etc. It's extremely rarely that lung nets secrete a chemical called histamine, which is often linked to allergic responses and allergic conditions. And histamine reactions often you'll see rash, red discoloration of skin. There could be hives. There could be some swelling. If you've seen somebody get stung with bee or some sort of food allergies, that's a typical histamine sort of reaction. It can happen in lung nets, extremely rare though. I think it's so rare that I don't think I can even quote you a number, a reliable number that 1% or 2% lung nets would have histamine. So the diagnosis vary based on classic presentation. If patient has a documented history of lung neuroendocrine tumor and has a very typical history of histamine, one of the things we check for that is do dermatographia, right? So I'll take a blunt object like a key and I'll write something on patients, maybe on the opposite side of hand, and then give it a minute or so. And patients with elevated histamine issue, that area wherever I've drawn something would actually manifest itself. It'll look a lot clearer and it'll kind of swell up and become red. So that's called dermatographia, and that's how we differentiate. Somebody think that, oh, they have carcinoid flush, but it's rather a histamine problem, because you would not see that with elevated serotonin, the dermatographia. So that those are some of the things, but the actual diagnosis based on the blood-based assays for histamines and other things.
Yeah, thank you for addressing that. Concerns about histamine does come up in the population, so thank you for that. So another topic and concept, you've mentioned that there is low or no SSTR, somatostatin receptor expression. So if there are low to no somatostatin expression, I guess why is that? And what does it mean? And then there's another question on here, what treatments might be appropriate, which I know you've talked about in your presentation.
This is one of the reasons why lung nets are a little bit more complex as compared to our GI or pancreatic nets, because the somatostatin receptor is not always present. Even if it is present, it might not be homogeneously present. That means it's not consistent. Some areas might have SSTR expression, others not. And then there are some neuroendocrine tumor patients, lung net patients, who won't have any SSTR anywhere. We often see that as an issue. So the first step we have to do is understand if we are dealing with SSTR positive patient or SSTR negative patient. So getting a dotatate PET is very helpful in understanding SSTR positive carcinoid versus SSTR negative one. Why it happens, I truly don't understand the biology of it. I don't think we understand it well, why certain lung nets are SSTR negative. And to give you a little bit depth of the problem, we don't really even have good animal models where we can study typical and atypical carcinoid. Unlike small cell lung cancer, we have a lot of really good models. We usually struggle in preclinical modeling, and that really impacts how we study these rare type of lung neuroendocrine cancers, to understand or improve our understanding of why they develop, how they develop, why some patients have atypical and others have typical, and how do they evolve. So all of those questions are currently being investigated in different labs, people who focus on this type of rare cancers. Hopefully in near future we will know why some patients have SSTR expression and others don't. But for now, what is more important and practical thing for us to look at is we have to understand there are patients who won't have SSTR expression, and it's important to get a baseline SSTR status on each lung net patient so we can tailor our treatment. And based on if it's SSTR positive versus negative, our treatment choices would be very different. So SSTR positive patient, as you saw in the presentation, we may start with somatostatin analogs, then jump on to PRRT, as compared to SSTR negative, where there is no role of somatostatin analog or PRRT, and we might have to start off with everolimus, which is an mTOR inhibitor. And then we have a new fantastic addition to our field with cabozantinib that's also very effective in lung nets. So we have to really depend on drugs which don't depend on SSTR targeting for SSTR negative patients.
So what it means, what you're saying, is that it helps guide the treatment decisions and treatment options.
Yeah. Absolutely.
And if I could ask a follow-up with that, does this SSTR somatostatin receptor expression change? Is it possible to change where you either can later on have expression or lose expression?
That's a great question, Lisa. And it can happen. We always have to keep that as a possibility. In GI world, my experience has that we don't see a major shift. So if somebody had a lot of SSTR expression, like a mid-gut carcinoid or a small bowel or pancreatic net, it usually would maintain that degree of expression unless there is a very small number of patients will have grade migration, becomes more aggressive or de-differentiated and loses that expression, becomes higher grade. That can also happen, but that's not the rule. That's not the common situation. In lung nets, I have seen the change in SSTR expression actually more frequently than GI or gastroenteropancreatic. In fact, with atypical lung nets, atypical carcinoids, where it's already heterogeneous somatostatin receptor expression to begin with, that means there's a mix and match. Some areas are SSTR positive, others are negative. Oftentimes, what happens is if we end up treating a patient with atypical carcinoid or a little bit higher grade variety cancer in the lung with some sort of chemotherapy, and in future, what we'll see is that that higher grade component got treated, and now we have the residual disease, which is more SSTR avid, and then we can maybe use some of our SSTR directed therapies. So I often try to reevaluate SSTR expression in future, especially if there's been a significant change or there is concern that certain areas are growing faster, but other areas are growing very slow. And so if there is a discordant biology or the way the tumor is behaving, it's important to understand how the SSTR expression is changing. That might give you some clue how aggressive or less aggressive you need to be in future progressions. So that can happen. I would definitely advise to, at some point, look into SSTR expression down the road after a few lines of progression.
Possibly revisit that.
Mhm.
So here's another excellent question. How is lung neuroendocrine cancer that is primary lung
Mhm.
and spreads to liver and bones, how is it treated differently from other neuroendocrine cancers that have a different primary origin, like GI and pancreas?
Great question. So a lung neuroendocrine cancer going to liver or bones is a different cancer. It's still a lung neuroendocrine cancer in the bone as compared to the pancreas neuroendocrine tumor into the bone. So subtle differences. Like I mentioned, a pancreas, for example, or a small bowel neuroendocrine tumor is almost always somatostatin receptor positive. Okay, unless we are dealing with a very high grade 3s, it's almost always SSTR positive. So our treatments are pretty well set. We'll start with sandostatin, lenalidomide, and then jump on to maybe PRRT. And we now have options like for pancreatic net, cabozantinib, CAPE-TEM, mTOR inhibitor, for midgut, mTOR inhibitor, cabozantinib. So we have these options. It's kind of pretty much set. For systemic therapies, of course, some patients may benefit from liver-directed therapy and surgery and other things. When it comes to the lung nets, so lung nets with liver metastasis, it'll still behave like a lung net. So what that means is it might not express somatostatin receptors. So you might have disease in the liver, but it's not lighting up on your dotatate PET. So all these SSAs and PRTs, these options will be out of window for us, and we'll have to look for non-SSTR directed therapies. Okay, those are some subtle differences. However, there are some commonalities. If it is a well-differentiated neuroendocrine tumor, like a typical atypical carcinoid, may not express somatostatin receptor, but that doesn't mean it's going to be very aggressive. It's like going to behave like small cell lung cancer. So I oftentimes also do FDG PET for these cancers if they are SSTR negative. And if they are not super hot on FDG PET, that means they're not hypermetabolic. I may often treat them like with other treatments which work very well in well-differentiated neuroendocrine tumors like Afinitor, mTOR inhibitor, cabozantinib. However, if it's an aggressive variety of SSTR negative disease that is growing very rapidly, patient symptomatic, and is lighting up very bright on FDG PET, I know that this is not like your typical carcinoid. This is kind of being very aggressive and doesn't have somatostatin receptor. So I'll often use chemotherapy. CAPE-TEM is one of them. If it's even higher grade, we might even use platinum-based chemotherapy. So it's a lot more nuanced, especially when it comes to atypical carcinoid. For typical carcinoid, SSTR expression is going to determine initial treatment choices. So those are the differences. So despite liver being one of the common sites of metastasis, the origin does play into how the tumors will behave and what treatments we will choose.
Yeah, that's really helpful. And, on the flip side, there was someone who submitted this question. So if they have a primary net, say in the duodenum, anywhere in the GI, and it spreads to liver and bones, how common is it to spread to the lung? I think that's maybe a concern, if you could address that. Does
Right.
it eventually spread, or is
It
this, common?
it's very rare. It's not the commonest site, for sure. The commonest site for your GI neuroendocrine tumors by far would be liver, lymph nodes, and bones. For a GI origin neuroendocrine tumor to spread into lung, it's very rare. Can it happen? Yes, but it's not very common. In our clinics, patients, in our program, we just see neuroendocrine cancers. Seeing hundreds of cases a year. We've probably seen all sort of permutation combination, but that doesn't mean that happens all the time, right? So it's very rare. However, because as I mentioned, bone is one of the top three sites we like to go to. Those bones could be in the thoracic cavity, like ribs or spine. So we always surveil for chest as well. So if somebody has duodenal neuroendocrine tumor, we just don't do abdominal CT and we call it a day. We also want to know, has it spread in the chest cavity? I'm less concerned about it going to the actual lung, but outside the lung, the lymph node areas, the bones, the ribs, and the spine. It can happen in the lung, but not a common presentation.
Thank you. And this question speaks to what about mixed presentation? So if someone's primary lung tumor shows uptake on a somatostatin receptor PET, but the metastases don't show uptake, and the biopsy of the liver shows a higher grade Ki-67 30% small cell poorly differentiated tumor, can the patient benefit from a somatostatin injections?
So pathology is the king. I will go by the pathological diagnosis. So pathologists say small cell poorly differentiated neuroendocrine carcinoma. We have a very distinct way of treating them. These are the NECs, the second half of the talk, and very aggressive cancers, rapid doubling time, and we often have to use chemotherapy. And now we have some newer immunotherapy options for them with DLL3 BiTE and certain other immunotherapy drugs, but very different cancer than a typical or atypical carcinoid. So usually we reserve SSA to a well-differentiated neuroendocrine tumor. Those drugs are cytostatic at best. That means it slows down the cancer, is not strong enough to cause tumor shrinkage. So for a small cell and poorly differentiated neuroendocrine carcinoma, SSA injection, I don't think are impactful and would be effective enough. And we don't really have good quality data to support that. We don't want to overtreat because these drugs, even if they're safe, they're not chemotherapies, the SSAs, but they still have financial toxicity. You still have to get once a month injection. So in absence of clear data that they help patients live longer or help stabilize the cancer longer, I would refrain from using SSA for small cell carcinoma, even if it's an SSTR positive. However, having said that, I'd like to take this opportunity to maybe cue in. There are some SSTR related radiopharmaceutical drugs like Lutathera. So SS will may have potential role in treating small cell carcinoma, especially those are SSTR positive, because those treatments are more effective. They are radiation based treatments, so there might be a role, and it's currently being investigated in small cell proliferative neuroendocrine carcinoma using different type of radiopharmaceutical targeting SSTR. Also a curious interesting point, the Ki-67 is about 30% small cell, which is usually not the case. Usually the small cell histology is much higher Ki-67, so it could be one of those things where you want to get pathology confirmed and make sure that that's what it is. Usually I would see 50, 60, 70, oftentimes even 90% plus Ki-67 for a small cell type of morphology.
Yeah, and good point. Thank you for raising that there are other treatment options for somatostatin receptor positive tumors. If there's tumors that light up and tumors that don't, are radiopharmaceuticals like PRT, is that still an option if some tumors light up and some don't?
Yeah, it's under the research protocol. So I would not advocate that, oh, we start doing off-label Lutathera, because we don't really know, one, safety, can be safely done, second, how much effective it is, because again, PRRT drugs are not completely without side effects. They're relatively well tolerated in most patients, but they're not without side effects. So a golden rule is we need to first confirm they benefit our patients. So if patients have access to clinical trials testing these radiopharmaceuticals and you are a good fit, I would highly encourage you to look into it. But I think a lot of drug development for NECs, the small cell and protein differentiators, is kind of leaning more towards DLL3 targeted therapies, especially these newer immunotherapies. So that's where we are seeing a lot more exciting data and promising data, which we also kind of thrown some light on the presentation. I would highly advise to consider those studies if you have small cell carcinoma, and those work regardless of SSTR status, right? So that's good. But right now, PRRT against SSTR in high grades or NEC is not ready for prime time. It's in first in human studies, and you don't want to use these drugs till we have better data, till we know if it helps.
Yeah, thank you for that. And for those who are looking for information on these trials, we do have them in our clinical trial guide, and Dr. Aman Chauhan has short little videos on that. So I do want to take another question in the NEC realm, and I know for some of you who did not yet watch the session B that highlights the NEC, you can go back and watch that on our website and YouTube channel. And I know you discussed the treatment sequencing for lung NEC on that video. But Dr. Chauhan, can FOLFIRI also work in lung NEC?
Another great question. NECs of lung, especially outside small cell lung cancer, have very few options. Large cell neuroendocrine carcinoma of lung has very few options. We often treat them like small cell lung cancer. And in small cell lung cancer, we use platinum-based chemo plus immuno as a frontline. After that, in the current era, we are going to be using tarlatamab or clinical trials with the L3 BITE antibodies in the second line space. For third line, we'll often use lurbinectedin or topotecan. Many people don't like topotecan, including myself, so I often use irinotecan. So in the lung space, we might use irinotecan by itself, and that's because that's how traditionally small cell lung cancer patients have been treated. FOLFIRI is not a very common regimen for lung NECs. It's very, very commonly used for GI origin NECs. This regimen comes from colon cancer, very, very commonly used. So I often use FOLFIRI for my extra thoracic neuroendocrine cancers. That means small cell or large cell neuroendocrine cancer of cervix or ovaries or gallbladder or colon or pancreas. Very, very commonly used. But for the lung NECs, we often sort of follow the small cell lung cancer paradigms, and we might have already used irinotecan because we use that, or topotecan. So we might not have the opportunity to use FOLFIRI. Having said that, anecdotally, where I've used it, I think it does work. A lot of these cytotoxic chemotherapies are not very tumor specific. There is a lot of cross activity. Even in FOLFIRI, as I said, one of the active agent is irinotecan, which is also used in small cell lung cancer or lung NEC. So that's one of the drugs there anyways. So FOLFIRI can work in lung NECs, but we do have other options that we often fall back on small cell lung cancer treatments for lung NECs.
Thank you for that. And you, meanwhile, answered another question that someone asked if NEC lung cancer acts like small cell lung cancer. So thank you for that. We're just going to take two more questions. There's actually two questions on radiation. Is radiation effective on lung NET? And if so, when is it recommended? There was someone else who submitted a question about possibly using radiation instead of surgery, and if that's safer for tumors that are close to the heart.
For an early stage lung NET, that means stage 1, 2, or 3, it's advised to do surgery, because by doing surgery, we can definitely say it's all out, it's gone. We can also do a good lymph node sampling that way. However, there are times where the risk of surgery might outweigh the potential benefit. For these, especially typical carcinoid, low-grade neuroendocrine tumors, patients may live for several years without probably even anything, right? That's just a natural history of disease. So if you have somebody at 90 years old, they might take that calculated risk that surgery might have higher risk, especially if there are comorbidities, heart conditions, diabetes, kidney issues, etc. So sometimes we don't need to take the drastic side of surgery. However, surgery is curative and is the standard treatment for somebody who's otherwise fit and is okay to go for surgery, understands the risk. But those patients who are not okay with surgery or are not fit enough to get surgery, or the risk benefit does not align, because of either age or comorbidities, then we have two options. One, to just not do anything and just observe and let it play out, see how tumors will behave. Some lung nets, especially typical carcinoid, may be so slow growing, it might take several years before they start growing or start having problems. So that's one strategy. The other strategy is to do radiation. I'm fairly impressed with radiation, especially the newer type of radiation like SPRT, where you don't really have to give weeks of radiation. It's just 4 or 5 or 6 days of radiation and you're done. It's highly focused, high intensity radiation in that area. And what that will do is it might not make the cancer disappear. You might still have that tumor that you will see. It might shrink it a bit, but it certainly slows it down. It certainly controls it for a really good amount of time. That is one of my concerns with keeping the tumor in the lung intact, because if it grows, eventually it will give shortness of breath, coughing, and some of the quality of life limiting symptoms. Again, if it's very tiny, may not be the issue, but if it's a large enough tumor closer to your main airways, down the road it might cause more trouble. And if you're not ready for surgery now, it might even be less likely in the future. So if you can radiate that sometimes can arrest the growth of that tumor, or sometimes even eliminate the tumor, but you'll still see that residual scar tissue left over. But we technically don't say we cured somebody after radiation. You still have to be monitored, make sure that doesn't come back. So there is definitely a role for radiation in the right patient, and I often use it in the right patient. I've had good experience. Don't expect drastic shrinkage like NECs. In NETs, typical, atypical, you will see some stability or mild shrinkage, but you will see that there'll be that residual tumor there, might be dead or alive, but you'll have to keep an eye on it.
Yeah, thank you for that thorough explanation. And for those who are interested in learning more about radiation and what you brought up, SBRT, our podcast episode that will be released later this month is actually on this topic. So we'll end with this last question. I know there's a lot of developments. I know you have a lot of passion and you're doing a lot of work in this area. So we thank you for that. But what new or upcoming developments are you most excited or optimistic about?
I think right off the bat, the biggest news, the tangible development that we can use right now for our typical and atypical lung carcinoma patient is cabozantinib. Especially for SSTR negative patients, for well-differentiated NET patients in lung, we had very few options. After Afinitor, we didn't really have much to offer. So it's really good to see that we have another targeted therapy that can be used for our thoracic neuroendocrine cancer patients. It's not FDA approved yet, but the data is very provocative. It's positive study, and I'm really hoping that we have an approval so that we can have easy access to this drug for all NET patients, including lung NETs. As far as the high-grade NEC is concerned, I think the biggest breakthrough in the recent past is the DLL3 targeted BiTE antibodies. We already have tarlatamab, which is FDA approved for small cell lung cancer. But there are now next generation of trials, ourselves at University of Miami, we are combining these DLL3 BiTEs with frontline chemoimmunotherapies or second-line lurbinectedin and topotecan. So once you find an effective treatment, you try to maybe make it even better by combining with other active agents. So I'm very excited about how this DLL3 targeting landscape is evolving. And of course, we need newer drugs as well and more targets. So stay tuned. There are a lot more exciting drugs in the pipeline with radiopharmaceutical targeting of SSTR in these high grades, with the DLL3 targeting of radiopharmaceuticals targeting those DLL3 in high grades. So there's a lot happening in high grades, and I think it was much needed. We had basically a stagnation of ideas or successes in high grade neuroendocrine cancer for a really long period of time, but things have started finally moving along. And so very, very excited for those advances.
And thank you for being part of pushing for those advances and making those things happen, because we need that. We need people like you who are the difference makers, who are committed to this field and to helping the NET patient community. So really, on behalf of the entire NET patient community, we really want to thank you for all your hard work, all you do to help people live longer and mostly live better. So thank you for all you do.
Thank you so much, Lisa. Thank you so much for this opportunity and great questions. And thank you, the audience and viewers, to tuning in. This is a great resource. I'll give a shout out to the whole LACNETS team for providing these wonderful webinars, lectures, and a lot of important educational resources on their website. So please check them out. And great to be here again. Thank you, Lisa.
Thank you. And I'm going to send it back to Heather in the studio.
Thank you again, Dr. Chauhan, for your truly comprehensive presentation and for answering specific questions on lung neuroendocrine cancer. We appreciate our supporters Novartis, Ipsen, Crinetics, Curium, ITM, and Exelixis. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at lacnets.org/donate. And through the end of the year, your donations will be matched. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high quality video production. Again, today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. If you registered for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey, as it helps us improve our content and with fundraising efforts. Again, follow us on social media to stay up to date with our upcoming events. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us for today's educational event. Goodbye, and see you at our next event.